what will be the ultrasound picture of an adenomyotic patch? I gave you the pathology. You have to now correlate your pathology with the ultrasound picture. Then only you can make out the exact ultrasound picture of adenomyotic patch. Let me put you the question now. If there is an adenomyotic patch over here, over here, over here, over here, what will be the echogenicity of the endometrial patch? Will it be hypoechoic or hyperechoic or anechoic?
Hyperechoic.
Dr. Sushma, not you. You know things better. You are taking the server-based course with us. You are with us since many months. Dr. Sushmita, I give you three options: hypoechoic, hyperechoic, or anechoic. You have any idea? Yes or no? Quickly. Probably have audio got disconnected. Okay, I will elaborate it very briefly. Now see, it depends. It depends on the blood. If it is old blood over there, then accordingly it will get decided by the blood. Now the point is, Dr. Sushma, you tell me, if I am seeing this patch over here and today it is 4 centimeters, and I am rescanning the patient after 4 days, 5 days, 6 days, or 10 days,
Yes, sir.
will it remain same? Yes or no? Over time, will it remain same? In a short span of time, will it remain same or it will change?
But it will change, but in a
It has to change. It will not remain change. It has to change if it is an adenomyotic patch. Because today there is blood which is 10 cc, tomorrow there is intermenstrual bleeding, it got escaped down, then automatically it will change. So the point, ultrasound point, please make a red note of this. If there is a rapid change in size and echogenicity over a short period of time, it is going in favor of adenomyosis. Because fibroids cannot change overnight. By overnight, I mean maybe 15, 20 days. But adenomyotic patches can. So this way, you can make out, because there is a lot of confusion when we are labeling these adenomyotic patches. So this is the rule. Rescan the patient. If you are having any confusion, rescan the patient. And if the size is increasing or decreasing, both, I mean any change in the patch size or even echogenicity, that is going in favor of adenomyotic patch. So in adenomyosis, we are having some ultrasound criteria also besides whatever we have discussed. Posterior wall to anterior wall, there will be discordancy. Mostly we are seeing these in posterior wall. So when you are measuring the anterior and the posterior wall, there will be the discordancy walls. And there will be hazy endomyojunction. Now see here, this is the myometrium, and this endometrium, and this is the myometrium. This junction will not be appreciated. So these are the additional. Now see over here, this is absolute loss of the endomyojunction. You cannot make out where is the endo and where is the myo starting. So this is also characteristic for the adenomyosis. So this way you can differentiate adenomyotic patch from a fibroid. Now, endometrial polyp. Let me take this as a final because final slide, because we have to show you patients also. We'll show you live patients also today, and we will discuss more on the patients now. You see, straight patients will not make sense if you don't know what to see over here. If you know this is the point, this is the explanation of this way I can make out this, then your hands-on and your patients, your practicals are automatically done. Now the endometrial polyp. Dr. Sushmita, you tell me, there is a suspected endometrial polyp. which day I can scan. I mean, when the picture will be clear, on which day I have to insert the probe, or even I have to scan the patient transabdominally. Dr. Sushma.
So during menstruation.
Very good. During menstruation, because not always we will be inserting the saline. There is a procedure where we are inserting the saline so that I will get a better picture of the polyps, but not always we can insert the saline, but there is a natural way of having some fluid in the endometrial cavity, and that is during menses. So if you are having any confusion regarding the polyp, whether it is there or not, so you are having an ambiguity over there, so better to recall the patient during menses. And this is the natural way of expecting some fluid in the endometrial cavity, if not even during menses, but don't scan the patient, don't diagnose or exclude the polyp when I am having a thick, hyperechoic, screentory endometrium. This is the point. So, yeah, now we will show you some patients. There is a lot more to discuss about this female pelvis. It will take days, months together and it will not get complete. So in this workshop, we gave you some brief of the female pelvis. Now let me switch to patients. So now these are the patients. Now in this patient, what we are doing, we are putting the probe in transverse section. This way the probe has been put in a transverse section, and we will be now taking the uterine sweep. This uterine sweep, now see the uterine sweep, what I mean by the uterine sweep, that I have to slide the probe this way, you see, from bottom to top. So it will be from the posterior most moving up. Now, if I am hitting the probe like this posteriorly, what I will be hitting? I will be hitting the cervix, and before cervix, I will be hitting the vaginal stripe. Then moving up, will hit the cervix, then body, then fundus, then it will show me the dome of the uterus. This way, the uterine sweep is complete. Now, see to the hand. This way. So you have to start from the bottomest part. In bottomest part, you will be seeing, now see, bottomest part, vaginal stripe, in transverse section, then moving up here, like this. Moving up, will hit the cervix, and then the upper parts of the uterus. Now see to the hand. So the probe, how we have to take the sweep. This way only, the whole of the uterus will get scanned in transverse section. See it again. And what we will do, you see, we will take the transverse sections like this. The whole of the uterus has got complete, and then I will move up so that the false pelvis is also scanned. So this way, in transverse section, whole of the uterus will get swept in a transverse section. Don't keep your hand static. If you will keep your hand static, then what it will result to is you will be taking one section of the uterus only, and if fibroid is not in that section, you will easily miss this. Then what we have to do, we have to rotate the probe by 90 degrees. And here I will give you one point, that the marker can go up or down. No book, not even Mr. Google will tell you this thing. Now, if you are moving it clockwise, your picture will be not this, but the mirror image of this. But if you will move it anti-clockwise, you will see this way. It means that you can rotate it both ways with what you are comfortable, but you should know what you are doing. All books, even Mr. Google, Calvin Fletcher, any book, they will be telling you you have to rotate it clockwise, not anti-clockwise. But if you know what you are doing, then you can rotate it. What you should know? You should know now that superior is this way if you are rotating it other way. That the superior is this way, otherwise the superior is over here. So your screen orientation will get reversed. So now you have to rotate the probe by 90 degrees. Now here, you will not move up and down. You will now move it sideways like this, small tiltings, so that whole of the uterus will get scanned in the longitudinal section. So this way, the transverse and the longitudinal section sweeps will get complete. So the point here is that don't keep your hand static. Now, this is the ovary. This is the ovary. This is another patient. Now, this is the ovary over here. The trick over here, the point what you have to see, when I am hitting the left ovary, I have to hit the left ovary through the bladder so that the beam will come through the bladder from opposite side. That is only possible through opposite side, not onto the ovary of the same side. Now, let me show you how it works. Now, see, imagine I am having the ovary, the left ovary. This is the left side, left ovary. I will be hitting from the other side, so that the beam will come through the bladder and hit the ovary. But I will not straightly keep the this probe onto the ovary. This way, I will miss the ovary. But if I will scan it from the other side, scanning through the bladder and hitting onto the ovaries will be much clearer and easily recognizable. Now see, this is not the transvaginal probe, but you can see the picture very clear because I am sending the beam through the bladder. So this is the point. You have to send the beam through the bladder and you have to slightly adjust the probe from the other side. Now see. Right ovary, while the probe slightly toward the left side, so that it will hit through the bladder, and bladder is here, it is hitting through the bladder onto the ovary, I can even see small follicles over there, very clear picture of ovaries. Why? Because I am hitting from the other side onto the right ovary. So these are the practical tips of the patients, how you are scanning the ovary. Now, I'll see, even if you will come over here, what you will see, you will not see this much clarity. No patient in world will allow you to show her or his tummy. See, over here, this is the longitudinal section, and this is the uterus over here. Now, the probe is put like this. Now, what I have to do, I have to tilt the probe, not jerky movements, not like this. Slight tilting towards this, and this side will now scan full of the uterus. This is the fundus of the uterus. This is the endometrial cavity. This is the cervix over here, and this is the vagina over here. This way. So this is not a retroverted retroflexed uterus, but this is an anteverted and anteflexed uterus. Had this been a retroverted uterus, then this fundus would have been dropped this way, here, this way. So this is how you can make out whether I am dealing with an anteverted or retroverted. Now see to the probe. I told you we have to move it sideways, slight tilting, so that I will be scanning whole of the uterus. See, slight tilting, sideways. So this way you can make a complete scan of the in the longitudinal section. Okay. So this is the cervix over here, and in cervix I can even see the mucus plug. So this is the cervix with the mucus plug. This is the mucus plug over here. And this mucus plug is telling me that this is the cervix. That is the point. So if you have to measure the cervix, it will be from this point to this point. So you have to roughly see where the mucus plug is. That will be the cervix. Okay. Now, if there will be any this Nabotham says that will be in the walls, and if that is already taken, Nabotham says will be now see again the uterine sweep. Now see again the uterine sweep. Will patient allow you to show if we are scanning together? No. So this is the online digital, which is more informative than sitting next to me. So this way we are taking the digital hands-ons when we are taking the server-based course. We are right now not taking a course. We are taking a short webinar of male pelvis. Now see, I told you the ovary, we have to hit from the other side. Now see, I am scanning this ovary. This is this side's ovary, right, left side's ovary. My probe is slightly towards the other side so that it is hitting through the bladder onto this ovary. Now see the beautiful ovary coming like the TVS picture, but it's not a TVS. Proof is over here. This is the transvaginal probe. Why there is clear picture? Because we are hitting from the other side through the bladder. This way we are taking the ovaries.